Hey guys, welcome back to my YouTube channel Crazy Myths. It gives me immense pleasure to post the second video of this channel after such a long break, and this video is going to be on pneumoconiosis. What is pneumoconiosis? It is a non-neoplastic lung reaction which is caused due to the inhalation of mineral dust. These dust can either be organic or inorganic particle. These also include chemical fumes and vapors. The pathogenesis of pneumoconiosis depends on the following factors, which include dust concentration, that is, the amount of dust which is retained in the lung. It is determined by the concentration of dust in the ambient air and also the duration of exposure to the dust. Next is the size, shape and buoyancy of the particle. Smaller the particle, the more dangerous it is, because it may reach the terminal small airways and air sacs where it settles down, causing inflammation that leads to fibrosis. And next is the solubility and reactivity of the particle. The particle which is more soluble is again more injurious, because these particles may cause acute lung injury, whereas the larger particle, they resist dissolution for many years and they persist within the lung parenchyma, which may later progress to fibrosis. And the effect of other irritants. The most common of these irritants is tobacco smoking. The tobacco smoke, it worsens the effect of all the inhaled mineral dust, which increases the pathogenesis of pneumoconiosis. And the most commonly involved dusts include asbestos, coal, silica, beryllium, barium, iron or tin. First, let us see coal workers pneumoconiosis, because it is the most commonly encountered pneumoconiosis in the world. It is caused due to inhalation of coal dust, which is most commonly seen in coal miner. It varies from simple coal workers pneumoconiosis to complicated coal workers pneumoconiosis, which is a progressive massive fibrosis. In both the cases, there is anthracosis, which is coal-induced pulmonary lesion. Here, the inhaled carbon pigment is engulfed by the macrophages which are present in the alveoli and interstitial spaces, and this leads to inflammation causing anthracosis. In simple coal workers pneumoconiosis, there is coal macules, which are small in diameter, that is 1 to 2 mm in diameter, and somewhat larger pigments are known as coal nodules. These coal macules consist of carbon-laden macrophages, whereas in coal nodules there are collagen fibers. These coal macules and coal nodules are found throughout the lung, but they are most common and is heavily distributed in the upper lobes and the upper zones of the lower lobes. The inhaled carbon particle may reach even up to the respiratory bronchiole, which is the adjacent side to alveoli, and it starts accumulating over there. In due course of time, it may lead to dilation of the alveole, causing centrilobar emphysema. Next is the complicated coal workers pneumoconiosis. Here, the lesions are very large and they appear as blackened scars, which ranges from 1 cm and even up to 10 cm. Microscopically, they consist of dense collagen fiber and the carbon pigment, and the center of these lesions are usually necrotic, as you can see in this picture, and this necrosis is because of local ischemia.
In complicated coal worker pneumoconiosis, the entire lung turns black in color due to deposition of coal and carbon pigments. Therefore, it is also known as black lung disease.
Coal workers pneumoconiosis is usually benign in early stages and cause only little decrement in lung function. But in less than 10% of the cases, it may progress to massive fibrosis, which is characterized by pulmonary hypertension, pulmonary dysfunction, and cor pulmonale. In the early stages, the progression to fibrosis can be prevented by avoiding further exposure to dust.
But once progressive massive fibrosis develop, it may continue to worsen even if we avoid further exposure to the dust particle.
Next, let's discuss silicosis. It is caused due to inhalation of silica, that is, crystalline silicon dioxide. It is most commonly seen in construction and road workers, and it usually presents after decades of exposure as slowly progressing nodular fibrosing pneumoconiosis. But occasionally, heavy exposure over months to few years can result in acute silicosis, which is characterized by accumulation of lipoproteinous material within the alveoli. Silica occurs in crystalline and amorphous form, but crystalline forms such as quartz, cristobalite and tridymite are more fibrogenic. The pathogenesis is after inhalation of the silica particle. They are phagocytosed by macrophages, and the phagocytosed particle causes activation of the inflammasome, which leads to the release of inflammatory mediators, particularly interleukin 1 and 18. These inflammatory mediators cause inflammation, which leads to fibrosis. Therefore, it results in advanced silicosis. Silicosis most commonly affects the upper zones of the lung. It may also involve hilar lymph nodes. Histological examination reveals a central area of whole collagen fibers with a more peripheral zone of dust-laden macrophages. Pulmonary functions are either normal or only moderately affected in the early course of the disease. But many people do develop dyspnea in advanced silicosis. There is also increased susceptibility to tuberculosis in these patients. They are also at high risk of developing lung cancer. Therefore, let's conclude the Pneumoconiosis Part 1 with this summary, that both cold worker pneumoconiosis and silicosis are more commonly present in the upper lobes or in the upper zones of the lower lobes. They doesn't show significant decrement in lung function, and silicosis usually presents after decades of exposure to the silica particle, but occasionally heavy exposure over months to few years can result in acute silicosis. The progression to advanced stage can be prevented by avoiding further exposure to the dust particle.
And I hope this video was useful. Kindly do like, share, comment and subscribe for Crazy Myths. Thanks for watching, guys.